Pain is not usually claimed as a reason for someone to request assisted suicide. It's a burden. It's the sensation of being a burden to others, being a burden to society. That is treatable. 90% of the patients in Oregon that request assisted suicide have mental illness. In fact, in the first decade of practice with this law, only 11% of patients were referred for psychiatric evaluation. The 10th year, that fell to 0%. Last year, it was 3 patients out of 370 that requested, so less than 1%. And that number, as far as requests, is up 25% from the year before. The safeguards in Oregon are not being followed. That includes the psychiatric referral, second opinion, and the 6-month time estimate for death. The failures are brutal when someone fails assisted suicide, and the failures are not infrequent. In fact, there was one that woke up from a coma after multiple days. There was a nurse at the bedside of one who ended up putting a plastic bag over the patient to kill the patient because they weren't dying. Predicting death is very difficult. There's a Mayo Clinic study recently, 468 hospice patients, and only with 20% reasonable accuracy predicting the time of death. There's significant advances in healthcare. Dying process can be in peace and comfort nowadays. Is PAS compassionate? It was legalized as a means to prevent suffering at end of life, but it targets unfairly those with disabilities, those with chronic treatable conditions, depression, and other mental illnesses, and even organ harvesting. I would call it elder abuse, and I would call it disabled abuse, and it is substandard care, and it discriminates. The majority of patients that request suicide are in hospice care, but the majority of hospice organizations are against it, and the majority of physicians are against it. So PAS creates challenges for the practice of palliative care, that is the physical, psychological, emotional, relational, and spiritual well-being of the patient. For palliative care is not to hasten or postpone death. In fact, there are some insurance companies in Oregon that stopped carrying cancer treatment drugs because PAS is cheaper. Next. What is your social milieu? It will change with this. I like to go back to the movie Field of Dreams starring Kevin Costner. It was a baseball movie. The great quote is, "If you build it, they will come." He was referring to baseball, but that's referring to all of our culture. If you will build this suicide opportunity, they will come, and it's going to create a negative social milieu. Let me read what a judge stated when this was first passed in Oregon. Where in the Constitution do we find distinctions between the terminally ill with 6 months to live, the terminally ill with 1 year to live, paraplegics, the disabled, or any category of people who have their own reasons for not wanting to continue living? Next. So change in society's attitude. Oregon's suicide rate has gone up overall, including violent, non-violent, not just those requesting suicide. Suicide is now the leading cause of death in Oregon. Elderly suicide is 156% of the national average. Suicide and despair are epidemic, and I think this law has contributed to it. Next. Oregon's made some recent modifications, including exempting the waiting period for some, but again, predicting death is very difficult. The drugs have changed throughout the decades, and I would consider that experimental, because sometimes they would work, sometimes they wouldn't. And now it can even take up to 2 days for a patient to die after taking drugs, where in the past it could take multiple days. There are still multiple failures. Next. What does PAS undermine professionally? Where there's a joy in medicine, there's a joy of relationships. I want to share one patient of mine who was near the end of death. In fact, I spent an entire Saturday with him the week before he died. We watched college football on the TV and drank bottles of wine and told jokes. There's an opportunity when you're given a sentence of dying with your medical condition to create relationships with others, to spend time with others, and to die in comfort and peace. Next. So the top 6 reasons why PAS should not be legalized. Financial incentive for early death, invites pressure and incentive to die by suicide, covers up abuse. It's not needed. It diverts efforts. It destroys doctor-patient relationship, and socially marginalized groups become marginalized. So I encourage you as a practicing physician and surgeon in Oregon for over 30 years, do not legalize physician-assisted suicide. Do what is right for your country. Thank you.
You will see behind any proposal for legalization of assisted dying that will be put on the foreground extreme cases of severe, unbearable, and otherwise untreatable physical suffering. And they state that doctors must be capable to stop this suffering by intentionally ending life. Behind this will always come the demand for assisted dying, for autonomy or fulfilled life. One must be able to choose the moment of the end of his life. So these two movements, motivations will always be present, but this one behind the first one. These are the number of euthanasia cases since 2002 in Belgium. We are reaching now 2,656 patients in 2019. On a global population of 11 million, this can seem a little number, but still it is 2.4% of all deaths, 1 out of 40 patients, and it's probably underreported, so it may reach 3.5% of all deaths. So this is not rare or exceptional anymore. Ending life becomes a routine. The underlying pathologies are mostly cancer, 66%, but also an increasing polypathology. This is the combination of beginning blindness, hearing loss, osteoporosis, dependency on others, 13% and doubling over some years. And then you have, for instance, also at the right, psychiatric diseases, 2%. We had patients with autism, for instance, who were euthanized. It's usually in the majority in terminally ill patients, up to 83% now of the cases, but still in 17% of cases, it's not terminal. And this group of patients, the non-terminally ill patients, is growing. It has more than doubled over 10 years. In our own hospital, you can see also that up to 30% of the patients are asking euthanasia in a non-terminal setting. The main reasons of request are very interesting to see. This is in hospital setting, so people with a physical disease. You can see that physical suffering is only 41% of the reasons for request. Then you have mental exhaustion, psychological existential suffering, social suffering, fear of future suffering, and concerns of autonomy. And both, often several reasons are combined. So it's not only physical suffering, and the cases that were shown in the media are, for instance, one of our famous writers who had the first signs of Alzheimer, a Nobel Prize winner who was facing alone his cancer, his children were living far away, a 34-year-old woman with autism, a transsexual who was unsatisfied with the results of surgery, and a 105-year-old woman tired of living. And Marc Kozijns, which is one of the founders of the bill, and also he's a lot in favor of euthanasia. Well, he says that today some persons who ask for euthanasia are not really patients. They should rather be helped with a law on assisted suicide, and maybe it should even not be doctors who decide about their demand, but social workers could do so. Every year, the Evaluation Committee on Euthanasia publishes a report, and then you can read, for instance, this kind of phrases, that almost in all cases, some kind of psychological suffering is reported. It's loss of autonomy, it's to depend on others, the lack of dignity. And even if his cancer pain is perfectly controlled, this person can still have unbearable suffering by the lack of autonomy. Therefore, in the end, all suffering is psychological suffering. And all suffering is also subjective. Therefore, in case of polypathology, lowering vision, lowering hearing, need for help while eating, incapable to go out of bed, incontinence, the combination of some of these can become too much, and they get tired of living, which can be a reason for euthanasia. Doctors, moreover, they may not be paternalistic and decide at the patient's place. This is old-fashioned. So in these circumstances, how can you then decide if a disease is severe and if suffering is unbearable or not? And how to apply the criteria of the law if everything becomes subjective? So this has as a consequence that all the conditions for a slippery slope are here present, because on one hand, the offer creates the demand. Once something is possible, people will talk about it and think about it. It will be considered as a right. And if you refuse it because the law is not really, the conditions are not fulfilled, then sometimes family or patients can become angry. It's not accepted. It's in a lot of cases in non-terminal situations. It can be for psychiatric disease, for polypathology. And finally, all suffering is subjective. And this is the start of the slippery slope. And then doctors finally become the judge of the meaningfulness of life. And as a solution for these problems, they have to administer death. Well, I think that this is twice not their job, because they have to judge the physical health of the patient, but not meaningfulness of their life. And they have to protect life, to increase life, but not to shorten it. This all is also putting pressure on palliative care. In only 39% of cases in 2013, in all cases of euthanasia, a palliative advice was asked for. So in the majority of the cases, we even don't look what palliative care could do. Palliative care is now seen as an alternative for euthanasia. It's the opposite, because patients will say, look, I don't want to go to a hospice and to live 2 weeks longer. My choice is to die immediately. So euthanasia is not the alternative. It's palliative care who becomes little by little the alternative.
The progression of the Canadian legislation. In 2016, Canada legalized assisted dying for those with a reasonably foreseeable death. Canadians believed this would be for exceptional circumstances of intolerable suffering when a person was dying. Since then, eligibility has been expanded through widening interpretations of the legislation and court rulings. For example, in Ontario, a 77-year-old person with osteoarthritis had euthanasia after a judge ruled that the reasonably foreseeable death criterion did not require a specific prognosis. In March 2021, the reasonably foreseeable death requirement was removed entirely. From March 2023 onwards, euthanasia will be available for mental illness as a sole condition. Progressively, safeguards put in place to minimize harm have been eroded, as they seem to serve as barriers to accessing euthanasia. Further expansion of MAID is happening in stages in Canada. A parliamentary committee is now exploring euthanasia for mature minors and advanced directives. MAID is also being requested for children. A mother's request for the euthanasia of her young disabled child is now being championed by our parliamentarians. Next slide. Under the current Canadian legislation, the eligibility for euthanasia now includes chronic disease. Some of the examples are listed here on this slide. Disability, which is very broadly defined to include anything that hinders a person's full and equal participation in society. Even deafness, blindness, and dyslexia would be included. And mental illness alone, as we've said, will be available in 18 months. Next slide, please. There have been over 20,000 assisted deaths in the past 4.5 years in Canada since legalization. We only have statistics reported till the end of 2020 at this point, but the numbers have been increasing each year. There was a 35% increase from 2019 to 2020. Assisted deaths now account for 2.5% of all deaths, with significant regional variation. For example, in Quebec, it accounts for about 3.1% of all deaths, and in British Columbia, about 4% of all deaths. The original picture painted of euthanasia being a rare event for very extreme circumstances, with estimates of about 100 requests in the first year, has not been our reality. Next slide. As in other countries who legalized assisted dying, Canada's data shows that requests are due to psychological and emotional distress around the fear of dying, including fear of being a burden to others, the loss of the ability to enjoy life, and a desire for control. It is not due to poorly controlled physical symptoms such as pain, contrary to the portrayals in the media and the euthanasia lobby groups. Next. At the outset, we were told in Canada that a carefully designed and monitored system of safeguards would limit harm and any risk of wrongful death of vulnerable persons. Yet every year, there have been documented cases of non-compliance with safeguards and misapplication of both law and policy with respect to MAID. The Chief Coroner of Ontario, the End of Life Care Commission in Quebec, the British Columbia Coroner Service, and the Correctional Investigator of Canada have all reported these issues. Next. We see reports of Canadians seeking euthanasia due to loneliness and depression from social deprivation and due to the inability to access the care and support needed for living through high costs of care, poor conditions in care homes, fear of loneliness in COVID lockdowns, and prisoners who are refused parole. Next. We also have reports of disabled Canadians being pressured by healthcare workers to consider euthanasia because of their ableist attitudes about perceived quality of life or the high cost of their care. One example is Roger Foley from London, here on the right side of the slide, who required 24-hour care due to a neurological condition. While in hospital, Roger taped a hospital administrator suggesting he should get MAID because of the cost of his care. Next slide. Many requests for euthanasia come from fear of being a burden to others. This sense of being a burden and loss of dignity is amplified when resources to support living do not exist. Disability rights groups have condemned the expanded Canadian legislation as making disabled people feel less valued in society by giving them a fast track to assisted suicide rather than suicide prevention and assistance in living. The Canadian Federal Minister for Disability Inclusion has said, in some places in our country, it's easier to access MAID than it is to get a wheelchair. Next. The impacts on medicine have been profound. Euthanasia in Canada has been radically normalized as routine medical care. The euphemistic language of medical assistance in dying has contributed to this by confusing and equating euthanasia with palliative care. MAID is represented as just another tool in the end-of-life care basket, but euthanasia is not end-of-life care. It is ending of life. This is a seismic shift for physicians. Next slide, please. The impacts on medicine are significant with respect to the role of the physician as well. Under Canada's legislation, a patient seeking an assisted death only needs to be told of their options for care, even for potentially treatable conditions. But being told about something and experiencing it and the benefits of treatment are very different. This allows death to be administered as a first-line treatment in Canada, and it has significant implications for a doctor's ability to practice medicine according to their conscience. Conscience is not about religion. It is about being able to practice medicine with professional and moral integrity, being able to provide recommendations within the scope of their specialty, in the patient's best interest and within the medical standard of care. A doctor, knowing of a treatment that can address the cause of the suffering leading to a euthanasia request that has not even been tried, is required to facilitate ending a patient's life because that is their choice. Many physicians can't do that in good conscience. Next slide. There is no robust legislation that can protect doctors, pharmacists, nurses, and others from having some involvement in facilitating assisted death, even when they feel professionally that is not indicated or necessary. Participation is forced in some of our jurisdictions through institutional policies and regulations, such as in Ontario, where the college requires doctors to make an effective referral and find a MAID provider or risk disciplinary action, such as loss of license. With the legislation expanding to those with chronic illness and disability, many more doctors are calling for better conscience protection, as almost every medical specialty is now being impacted by MAID. Next slide. Assisted dying has been romanticized as the most beautiful death and marketed as the only way to die with dignity. This has perpetuated myths and increased fear about natural dying and death, which is most often very peaceful and comfortable. And specialist palliative care must be made readily available to support a comfortable death for those few people with more complex symptoms. Those who voice concerns about patient safety or advocacy for the safeguards needed to prevent wrongful deaths in Canada have been dismissed as being anti-MAID or accused of trying to block access to MAID. We are also experiencing significant bullying and marginalization within medicine and institutions for those who are not championing euthanasia. This is causing division and conflict within the medical profession. In my experience, there is not a day that goes by now that doctors are not facing an ethical dilemma or moral distress about euthanasia. It is exhausting and demoralizing. Many colleagues have stopped practicing palliative medicine because of this. I keep going by knowing that those patients who do not want euthanasia will not have other options for care if we all leave. Next slide. I'd like to end with this quote from Canadian bioethicist and physician, Dr. Nuala Kenny. Legalizing euthanasia fundamentally changes medicine, the role of the doctor, and our society. Once brought into medicine, there are no rules or safeguards that you can put in place that will keep euthanasia restricted to a very few with extenuating circumstances, as is portrayed by its proponents. Don't be deceived. Administering death is cheaper and easier than providing care. and it will quickly become the solution for any form of human suffering, as we are seeing now in Canada, period. It is not a slippery slope. It is a logical progression. Thank you.
Based on our experience in our state, the three most common, frequently reported concerns that lead to seeking this option was decreasing ability to participate in activities that made life enjoyable, losing one's autonomy, loss of dignity. These are societal issues. It is so common. Culturally, it's often people refer to this far more than being medical problems. Inadequate pain control or concern about it is a reason in less than a third of the people as the reason for choosing Death with Dignity Act in our state. So what exactly is involved? I mean, I had to reflect on this to let this sink in. This is what Lisa from California described of her aunt's assisted dying. She was there in that moment. The full cocktail included 2 anti-nausea pills, an anti-seizure pills, and 100 capsules of secobarbital. My attention turned to the kitchen table where my husband and sister, wearing latex gloves, frantically scraped the powder from 100 capsules with toothpicks, trying to beat the clock. The mountain of powder we poured into more sugar syrup created half a cup of sludge so bitter it literally burned my tongue. The day was fraught and frightening. We had been forced to assist in the most bizarre fashion, jumping through seemingly random legal hoops and meeting arbitrary deadlines, while my aunt suffered, and finally emptying capsules, making an elixir so vile, I cried when I knew she had to drink it. This was death with dignity. There is no dignity in this kind of death. And you heard from the previous speaker, sometimes it drags on for 2 days. I had to reflect on this to let this sink in as a physician, having worked hard, having dealt with patients who are suicidal, who have completed suicide and died by suicide. So this is probably what it really means. Most individuals requesting this do not carry a diagnosis of depression on their chart. However, studies have suggested that quarter to half of the requests came from individuals with depression. Unfortunately, as you heard in Oregon, only 1.2%, that's 3 of those who requested, were referred to psychiatric consultation in 2020. Many more may have undiagnosed treatable disorders such as depression. For patients, for example, patients diagnosed with cancer are at high risk of dying by suicide. Did we end up missing treatable causes? Is always an open question for me. Let's go to the next slide, please. It's an ethical slippery slope. We are dealing with death on demand, with physician shortage in both our countries. Difficult to have physicians to remain with the patient when they self-administer the drugs. In 2020, for instance, only 11.8% of the patients, the physician was present at the time patient ingested. Nearly 48%, there was no one there. If patient wakes up, what do you do then? They're told not to call 911, not to take them to emergency, as that will lead to police report. And in about a third of them, they're ambivalent. They're not deciding which way to go. There's always the ethical dilemma, as some physician and hospice care providers feared breaching their institutional policies and becoming subject to litigation and abandonment. Death on demand, physician-assisted suicide or euthanasia is not part of hospice and palliative care. One participant explained it so well. This is a sudden end to death, a more determined time, date where life will end. In 2020, for instance, the patient-physician relationship was 8 weeks, anything from 0 to 1,020 weeks. There was not much time or relationship with the patient to evaluate the patient completely and decide which way to go. So let's go to the next slide, please. Dead don't speak. There is zero accountability, oversight, and no complaints so far. We have been having this law for close to 20 years now. Law does not include any oversight or regulation, and the records are destroyed after 1 year. The death certificate simply says death as from natural causes. Only 2.2% of the Oregon physicians prescribed it. This is an unregulated practice. As there is no peer review, medical board is not aware of who practices what they prescribe. There is serious risk for safeguard and requirements to be ignored. It has become like a runaway train, and we have to be cautious, and please do not allow this to be an option in your country before you lose track of what is going on.
In Belgium, the laws on palliative care and euthanasia were voted through at the same time in 2002. Since then, all media attention has gone to euthanasia cases, and palliative care has failed to receive either comparable public attention or sufficient and promised financial support. As a consequence, when reflecting about the end of life, my patients have only two ideas in mind. Either they will suffer or they will ask euthanasia. It's a horribly grim choice, and it shows an enormous ignorance about palliative care and its benefits. For me, this situation is a good occasion, a good opportunity to propose them palliative care as the third way, and explain them the tremendous possibilities of palliative care nowadays. In 2002, when the law was voted through, euthanasia was presented as a rare exception of the legal prohibition of killing, permissible only in rare cases of extreme, uncontrollable suffering in terminal patients, for example, in those suffering of asphyxia, those with extreme pains, or those with pre-terminal anxiety, and also made at the request of an adult with mental capacity. Now, almost 20 years later, euthanasia is increasingly applied to take the lives of non-terminal patients, like psychiatric patients or older patients with the so-called polypathology, a combination of different non-terminal diseases and conditions in the elderly. Sometimes euthanasia is proposed by healthcare workers to patients directly as recommended solution to their suffering. As we show in the book Euthanasia, Searching for the Whole Story. It has become considered as the good way of dying. We as a society went from tolerating euthanasia to normalizing it and conferring upon a moral acceptance. And we have now reached the situation where euthanasia has become a banal and everyday fact of life. The number of deaths by euthanasia has increased incrementally each year as the practice of euthanasia shifted from the initial idea of an exceptional procedure for exceptional situations to the absolute right of the patients to end life when life is considered not to have sense anymore. Yet, palliative care is the opposite. It is the opposite of this. Palliative medicine is about doing everything to give a sense of meaning and purpose to the last days of life, to stimulate care and solidarity. Tragically, it has become extremely difficult to give good palliative care while a patient has the euthanasia paperwork ready in the nightstand and asks for euthanasia on a difficult day, requesting another doctor if their request is not immediately granted. The doctor and the whole palliative care team are then transformed into an instrument of the patient's desire, amputated of their vocation to care and to heal, and treated like furniture. I do not believe in the so-called integrated palliative model, a model where palliative care and euthanasia go hand in hand. The evidence suggests the opposite to be true. In palliative care, the patient and the doctor share a commitment, an alliance. Doctor and patient accept that they have a real responsibility towards each other. The ultimate aim is clear. In the end, a death with authentic dignity, respecting the ethical framework of both patient and doctor. The way to get there is intrinsically different between palliative care, which is about guiding the patient through the natural process of dying, and euthanasia, which is intentionally inducing death on the patient demand. With euthanasia, the patient-doctor relationship becomes a contract, and the doctor is turned into an instrument of delivering death. Another evolution which shows that palliative care and euthanasia do not go together is this. Initially it was thought that euthanasia would only be accepted after applying the so-called palliative filter, which means that first, all the possibilities of palliative care should be proposed and discussed with the patient requesting euthanasia. Now, almost 20 years later, applying the palliative filter is attacked. It is attacked as a barrier impeding the patient to receive the euthanasia he wants. Now it is said, by proposing palliative care, doctors obstruct patients who want euthanasia. It is even illegal because trying to convince a patient about a certain management is against the law on patient rights. That's where we are. The palliative filter sounded like a nice theoretical concept when the law was developed. Now, almost 20 years later, we see it does not work at all. As euthanasia becomes normal, the right of conscience of doctors and health workers is increasingly under pressure. As euthanasia is considered as the good way of dying, why should a doctor refuse? Is he heartless? Without any empathy? The pressure of the family on doctors to administer euthanasia is heavy. Nobody cares about mental and emotional charge on doctors performing euthanasia, how it changes them, and how they try to cope with it. A citation from the book Euthanasia, Searching for the Full Story. I had the pleasure to coordinate this book together with several experts from Belgium. In this book, a nurse writes, I have been witness of the deep distress that doctors experience when they perform euthanasia, such as one experienced and qualified doctor. His eyes filled with tears as he confessed that some nights he wakes up in sweat, seeing the faces of the very people he has euthanized in front of him. Be aware that once the door of assisted suicide euthanasia opens, it will always open more. That's the way it has gone in Belgium and in all the countries without exception where euthanasia has been legalized. You would be deluding yourself if you imagined that it would be any different in the UK.